to get together. It's a pleasure to be with all of you. Wish you a warm good evening from a cold morning in Connecticut in the northeastern United States. And the mission I was given, and let me call on the organizers just to let me know if at any point there's any difficulty with seeing the slides, advancing the slides on time, or audio. Please just shout that out to me. I'm going to assume if I don't hear complaints that you can hear me and see my slides. And I was asked to talk about the evidence-based case for diet as a vital sign. So I'm going to dive right in, assuming my slides behave. And I'm actually going to make the case that from my point of view, this story, the story about diet as a vital sign, and the story of my career really dovetail. So if you note the date on this paper, you may be used to seeing more current citations, and maybe you think I haven't been doing my homework because I'm showing you a citation from 1993, but actually that's important. So this is 30 years old. I readily acknowledge that. It was an important time in my life. I finished medical school in 1988, my internal medicine residency in 1991. 1993 was when I finished my second residency in preventive medicine, public health, and I was really trying to figure out, okay, now what do I want to be when I grow up? And I did my training at Yale in preventive medicine, in particular because I was interested in adding clinical research to a clinical career. I was already committed to seeing patients, but I wanted to do clinical research. I wanted to study research methods, epidemiology, and so forth. And like most researchers, my intentions were to boldly go where no one had gone before, just in case there are any Star Trek fans in the mix. I wanted to ask questions nobody had thought to ask and probe for answers nobody had. That's what researchers do. And then this paper came out and it changed my life. Actual causes of death in the United States. Now, I realize I'm speaking to a group mostly in India, and I'd like to excuse the ethnocentrism because this could have been actual causes of death in the modern world. It just so happens that Mike McGinnis and Bill Foege focused on epidemiology that was readily available in the US, but this is really reflective of the modern world. What they did was say, we think of causes of death as what gets written on death certificates, often by sleepy doctors in the hospital very late at night. And usually what they capture there is just the immediate or proximal cause of death. So, for example, if someone dies of cardiogenic shock, secondary to congestive heart failure, secondary to myocardial infarction, the death certificate doesn't go any further than that. It stops at myocardial infarction, cardiogenic shock. What McGinnis and Foege said was, wait a minute, what caused that? What caused the myocardial infarction? And if we back that up a step, okay, atherosclerosis of the coronary arteries, what caused that? They were probing for the root causes. And when they were done analyzing a vast tome of data, they had enumerated a list of 10 factors which collectively explained almost all of the premature deaths that occur in the US every year. And again, by extension, this is really relevant to much of the modern world. And all that was really left to explain was a rounding error. And what was really important those 30 years ago was that everything on their list of 10 was modifiable. And not just modifiable now, modifiable then. In other words, we knew how to fix what was broken all the way back in 1993. What captured my imagination as a newly minted preventive medicine specialist is that the first three things on McGinnis and Foege's list of 10, all by themselves explained 80% of the variance in total mortality risk, or the risk of premature death in any event, and total chronic disease risk. And those three things were bad use of forks, feet, and fingers. And by fingers, I mean bringing cigarettes to our mouths. So back in 1990, the number one cause of death, premature death, was tobacco use. Number two was poor diet, and number three was lack of physical activity. Okay, so I decided then and there, if we could just fix use of feet, forks, and fingers, we could eliminate 80% of chronic disease and premature death in the modern world. I can no longer justify being a researcher probing the unknown when we could do so much with what we already know. Knowledge isn't power if we don't use it. We have the knowledge, we just aren't using it. In any event, feet, forks, and fingers, leading causes of premature death in the US and the modern world. So I decided I would devote my career to those things. And in particular, I focused on forks or dietary patterns for a couple of reasons. One, physical activity may be hard to do, but it's simple to understand. More is good, less is bad. Tobacco is also very simple. Smoking is bad, not smoking is good. People were confused about diet, and I thought that's where they needed the most help. This issue, the leading root causes of premature death, was revisited 10 years after this original paper. And the same conclusion was reached in 2004 as in 1993. The only thing that had changed over the span of that decade is that the gap between tobacco as the number one cause of premature death and the combination of bad use of feet and forks as number two had narrowed. It had narrowed partly because of less smoking, at least in this part of the world, but also because diets continued to deteriorate, physical activity levels were terribly low. So this validated my choice to focus on nutrition. And if we flip this coin over, so we now know that diet for the past 30 years has been on the list of top three causes of premature death. If we flip the coin over and ask, okay, can we do good? The answer is yes. So this study, this was a nested study in the EPIC study of cancer throughout the European Union. This particular study looked at 23,000 adults living in and around Potsdam, Germany. So the investigators looked at four factors. They basically asked these 23,000 people, do you smoke, yes or no? Do you eat well, yes or no? And they used a very simple definition of eating well: habitual intake of fruits, vegetables, and whole grains. So yes or no to that. Are you physically active on a regular weekly basis, yes or no? And is your weight in a healthy place, yes or no? And what they went on to do was to compare the two ends of the spectrum. So they compared, yes, I smoke. No, I don't eat well. No, I'm not physically active, and my weight's not in a healthy place. So four bad answers. To no, I don't smoke. Yes, I eat well. Yes, I'm physically active and my weight is fine. Four good answers. And when they compared four good answers to four bad answers and followed these people over a span of years, they saw an 80% lesser incidence of all major chronic disease. So think heart disease, cancer, stroke, diabetes, etc. 80% less in the group with four good answers than the group with four bad answers. And they found that if you flip the switch from bad to good on any one of these four factors, the probability of any major chronic disease over time went down by 50%. But fire on all four cylinders, and the probability of developing pretty much any major chronic disease went down 80% if you didn't smoke, ate well, defined quite simply, were physically active, and by virtue of being active and eating well, winding up with a healthy weight. And then the power of nutrition doesn't stop just at the level of epidemiology. We can actually follow it into cell biology, into the very coil of DNA. And in fact, it gets right at the issue of the power dynamic between nature and nurture, which we've long debated in medicine, which is more important, what is endowed to us biologically or our upbringing. The reality is we can, in fact, nurture nature. DNA is not destiny. So the study I'm showing here back in 2008 in the PNAS was by Dean Ornish and colleagues. They were looking at 30 men with early stage prostate cancer. And as the clinicians in the group likely know, in its early stages, prostate cancer is amenable to what's called watchful waiting. In other words, you may not need to treat because the cancer may not progress, but you've got to keep an eye on it. But Ornish and colleagues thought, well, we can do better than just let these men wait to see whether or not their cancer progresses. Let's give them the benefit of lifestyle as medicine. And so they did. And in fact, they fired on all six cylinders of lifestyle medicine, which I describe as feet, forks, fingers, sleep, stress, and love. In other words, physical activity is feet, dietary pattern is forks, not bringing toxins to our mouth like tobacco is fingers. And then sleep, we need enough. Stress, we need to avoid too much. And love, we need good, healthy social connections with other people because no one is an island. So they addressed all six, but in particular, they emphasized optimized plant-based nutrition. And then over a span of months, they examined not so much the men and not so much the cancer in the men, but preferentially the genes in the men with the cancer. And what they found was that this lifestyle intervention took 500 cancer promoter genes and turned them off, and 50 cancer suppressor genes shown here and turned them on. Left is before, right is after, red is off, green is on. So these are genes being activated, cancer suppressor genes being activated by a diet and lifestyle intervention in men with prostate cancer. Subsequent studies have shown that this kind of intervention significantly extends the PSA doubling time as well. And this is not just one study. I'm showing you one study, but this is a whole branch of the literature that continues to expand with each passing year. We also know that we've sort of left the era of genetics and genomics behind to some extent because we've moved into the era of epigenetics and epigenomics. I trust you all know that 95% of our chromosomal real estate is not genes. 95% is the levers and switches that control what the genes do. So about 5% of our chromosomes is taken up by genes, 95% is the epigenome. And while our genes are fixed, the genes we have are the genes we're going to have, the epigenome is fluid, it's malleable. Our behavior can change the behavior of our epigenome. We can change the settings for those levers and switches, and they in turn can change what the genes do. So this study from just under 10 years ago in the New England Journal of Medicine looked at that very issue. What if we recruit adults at high genetic risk for coronary artery disease and give them a lifestyle intervention, optimal diet, all the good stuff I just described? Can that overcome what essentially they got from nature? Can we nurture away an adverse nature? Bad genes leading to increased coronary risk, can we fix it with lifestyle? And the answer was yes. The lifestyle intervention cut the incidence of coronary events, both acute coronary syndrome and death, by more than half. So even when the genetic deck is stacked against you, you can modify outcomes by changing the behavior of those genes, essentially influencing the epigenome with diet and lifestyle. And then finally, on the genetic topic, this is obviously an important area, we can even alter the architecture of our very chromosomes with lifestyle. So those green tips you see at the ends of these chromosomes are obviously telomeres. You've all heard of those. And the length of telomeres, other things being equal, corresponds to the length of healthy lifespan. And in research involving Elizabeth Blackburn at the University of California, San Francisco, and others, and Dr. Blackburn is a Nobel laureate for this very work on telomerase activity. It's been demonstrated that lifestyle interventions can lengthen telomeres. So we can modify the epigenome and change gene expression, gene behavior. We can even alter the architecture of our chromosomes with diet and lifestyle. I could probably stop now and say, okay, there's the case for diet as a vital sign. What could be more important than interventions that can alter us at the genetic level? But I'm going to keep going. Another important area as we move away from genetic focus is the microbiome. Obviously, we're hearing about that all the time. We're hearing about the gut-brain axis. We used to think that the microbiome was important for digestion. We now know it's important for absolutely everything. And I trust many of you have heard the expression, it takes a village to raise a human being. I think in the era of the microbiome, we can add a corollary. It takes a village to be a human being because there are more bacteria in us than cells, probably by an order of magnitude. There's more bacterial DNA in a human than there is human DNA, at least numerically, if not by mass. And we can't function without them. Critical components of our endocrine system, critical components of our neurological system, critical components of our immune system, and on it goes. So because there's recognition that the microbiome is so important, and because it's very clear that diet influences the status of the microbiome, one of the issues that's emerged, at least in pop culture, is, okay, should I now be eating in a different way to feed my microbiome? Should I forget everything I thought I knew about nutrition and eat to feed my microbiome? So this study, Healthy Food Choices with Gut Microbiome, the associations here, gets right at that issue. Do we need to eat differently for our microbiome than we need to eat for ourselves? And of course, the answer is no. It wouldn't make any sense, right? Healthy people are healthy people. And just like healthy people have healthy livers, healthy people have healthy microbiota. I think the best way to think of the microbiome is as another vital organ. You don't eat differently to feed your kidneys than you eat to feed your liver than you eat to feed your heart. You're either eating a diet that's good for you or you're not. And if you are, it's good for all your vital organs. Well, the microbiome is just another one. So this study concluded exactly that. Large population-based survey confirmed that fiber-rich dietary choices are associated with a healthy microbiome, essentially. Greater potential to produce short-chain fatty acids, which is one of the key areas where the microbiome produces active metabolites. So the punchline here really is what's good for us is good for our microbiome and vice versa. And it wouldn't make sense if it were any other way, because again, it would be the same as hearing, okay, if you eat to be healthy, it'll be good for you, but it won't be good for your liver. That makes no sense. So what's good for us is good for us, and the microbiome is part of who we are. So we've known easily for 30 years, and we could make the case we've known a lot longer. Some people would argue we've known since Hippocrates that food really should be our medicine and medicine should be food. And we like to say that knowledge is power. But essentially what I discovered back in 1993, when that first paper I showed you came out, Actual Causes of Death, knowledge isn't power, because we often fail to translate what we know into what we do. And consequently, I've devoted my entire career to that space, translating what we know into what we do. And I can't say that I've necessarily succeeded. You be judges of my efforts, because we've got a long way to go still, but I've been trying, because knowledge isn't power if you don't use it. And we have failed to use what we know about the power of diet and lifestyle to modify the human condition. And because of that failure, the situation has mostly gotten worse. Note the date. This is an op-ed, an opinion piece in the New York Times. The authors here are Dariush Mozaffarian, who until recently was Dean of Nutrition at the Friedman School at Tufts University. He's still a professor there and runs the Food as Medicine program. And Dan Glickman is a former U.S. Secretary of Agriculture. And then note the title of this op-ed, Our Food is Killing Too Many of Us. And then finally, note the timing of this, August of 2019. Just a few months later, we were into the start of COVID-19. So essentially, this was an announcement about a pandemic we already had. What Mozaffarian and Glickman pointed out in this op-ed, based on data from the Global Burden of Disease study, is that poor diet quality, not hunger, not lack of food, but just too much junk where food ought to be, was responsible for over 500,000 premature deaths in the US alone every year. And this is a global problem, as I'll show you in a minute. So this truly is not just an epidemic here, it is a pandemic. But interestingly, we had a moment of national reflection, mourning, silence, grief, when more than 500,000 people in this country died as a result of the COVID pandemic. But more than 500,000 people died prematurely as a result of this food pandemic, junk where food ought to be, every year. And it hides in plain sight. And to be clear, this is not just a US problem, although we probably are the world leader in inventing junk to substitute for food, but we've done a very good job of exporting it all around the world. So in fact, in the Global Burden of Disease study, as seen here in the Lancet, in 195 countries around the world, in dozens and dozens and dozens of them, diet and poor quality food is the single leading predictor of premature death and chronic disease. So remember, we started in 1990 with the paper by McGinnis and Figi published in 1993. Poor diet quality was in the top 3 causes of premature death and chronic disease. In 2024, poor diet quality is the #1 leading predictor variable for premature death and chronic disease risk in the modern world, full stop. So I have to say I'm happy with the choice I made to focus my career preferentially on nutrition, because that's what we do in medicine. We try to fix what's broken, and wow, is this badly broken. So that's the situation. And I've mentioned the COVID pandemic just because of the timing in particular, but I think it's important to note that this pandemic of bad food and poor diet quality and the COVID pandemic intersected. So when colleagues and I looked early in the pandemic at data coming out of initially Wuhan, China, but in particular Seoul, Korea, and then Lombardy, Italy, one of the things we saw is that COVID was much more severe in people with chronic conditions and much less severe in people who were healthy. And so we looked at the prevalence of these conditions that seemed to make COVID a more dangerous disease in the US, and we found that 6 out of 10 Americans had at least one of these conditions: obesity, diabetes, hypertension, etc. 4 out of 10 had at least 2. The New York Times picked up this work in this article here and looked at the potential overlap between these chronic cardiometabolic conditions and COVID, and warned that there was a train wreck coming, and it came. So essentially, people with obesity, diabetes, cardiometabolic disease were much more likely to wind up with severe COVID. We're much more likely to wind up in the hospital. And we're much more likely to die. And as I trust you all know, the US had one of the highest mortality rates from COVID of any country in the world. And obviously, we've got lots of resources to respond to the pandemic. But what we also had was lots of cardiometabolic disease. So it was really the prior pandemic, which at its origins relates to lifestyle and too much junk where food ought to be, that was really responsible for the mortality toll of COVID in this country. And this paper in Jaha looked at that very issue. This was a modeling study. Dariush Mozaffarian, again, the senior author here, and using computer modeling and looking at how cardiometabolic disease was contributing to COVID, they estimated that if we had better cardiometabolic health in the general population, the mortality toll and the hospitalization rate from COVID in the US would have gone down by 60%. Keep in mind, this is without doing anything specific to protect against COVID. So they weren't looking at masks and they weren't looking at vaccines and they weren't looking at treatments. They were just saying if we had addressed the prior pandemic of lifestyle and diet leading to massive prevalence of cardiometabolic disease, if we had just been healthier coming into the pandemic, 60% fewer hospitalizations, 60% less mortality. That's incredible. So this was really a tale of two pandemics, and the one we all went through recently together was much, much worse in the modern world than it needed to be because much of the modern world was unhealthy, and much of the modern world is unhealthy because of lifestyle and diet. And then this study in BMJ Gut looked more specifically at the issue of objectively measured diet quality using the Healthy Eating Index and COVID severity, and found a direct correlation. The higher the diet quality, or direct inverse correlation, the higher diet quality, the lower the rate of severe COVID infection, the lower the risk, and the lower the diet quality, the higher the risk of severe COVID. So in other words, eating well seems to protect against, not obviously not against getting SARS-CoV-2 or any of its current variants. You're just as likely to get exposed and get infected, but the severity of the infection varies inversely with diet quality. Diet quality is protective. And throughout much of the pandemic, I was talking about this. I don't know if any of you follow my writing and ranting on LinkedIn, but if you did, you saw some of those, and I had a YouTube channel. And this was one of the themes I kept emphasizing. We need a get healthy now movement for the modern world. If we want to combat COVID-19 and its toll, we can't just be looking at this pathogen. We need to be looking at the host. And the host tends to be very unhealthy with cardiometabolic disease. Why aren't we talking about improving diet quality for everybody? Why aren't we having online programs to help people exercise even in their own homes? Let's do community dances that are mediated for free on YouTube and social media. Let's help people be physically active together. Let's help them eat optimally. There are all sorts of things we could have done to get healthy together. And if we had helped people reduce inflammation, lower weight, improve blood pressure with lifestyle during the COVID pandemic, we would have reduced the toll in much of the world. But we did none of this. And this is an article, obviously, as you see in Politico, that raised the same point I did. Diet is directly related to the toll of COVID. Nobody's talking about it. I was talking about it, but I was pretty lonely. And although we know perfectly well how to prevent obesity, we didn't need Ozempic to fix obesity. We knew what to do with our feet and our forks all along that would make most of the problem go away. It just keeps getting worse. So just another example that all around the world, knowledge isn't power. We know how to fix these things. We're not fixing them. And the reason we're not fixing them is the obvious one. It's a one-word answer. Anybody want to guess? The one word is money. Right? There's lots of money to be made making people fat and sick. We are, aggressively victimized by the makers of big food, marketing to us, marketing to our children. Essentially, there are large industries making tons of money that sell us the stuff that makes us fat and sick, and then other large industries making tons of money to sell us the remedies for diseases we never needed to get. Look what's happening now with the GLP-1s. Instead of saying, hey, we have pandemic obesity and we could fix it by elevating the quality of food. No, it looks like what the world's interested in doing. Let's keep eating junk where food ought to be. Let people get fat and sick. and then spend tons of money on Ozempic and other drugs to fix what never needed to break in the first place. And round we go. Anyway, all these problems just keep getting worse, and there's a projection from the World Obesity Atlas here that 1 billion people are estimated to be living with obesity within this decade. And this is obesity. This is not overweight and obesity where the numbers are considerably higher. And by the way, here in the US, 70% of the adult population is overweight or obese. In India, as I trust many of you know, it's a related but somewhat different problem, the issue of lean obesity, where essentially there is a genotype, phenotype, preferential deposition of fat around the middle, preferential development of visceral fat, metabolic syndrome, insulin resistance, type 2 diabetes, even with BMIs well below 25. And so, we need to be looking at this through a multicultural lens if we really want to understand the scope of the global problem. And obesity was a direct driver of international differences in COVID-19 death rates. Where there was more obesity, there was more death. And the mechanisms of this have been pretty well described in the literature. And now there's evidence that obesity is a significant risk factor for long COVID as well. And of course, we're all hearing a lot about that in the literature. And that's a problem we really don't know how to address very effectively. But all the same risk factors seem to pertain to long COVID. So you could think, as many people seem inclined to do, that, okay, so, if obesity is so dangerous, obesity is the disease and we need drugs to treat obesity. I don't think that way. 100 years ago, almost nobody developed obesity, and our genes were exactly the same. This is not a failure of human physiology. This is a failure of the modern environment. We have way too much junk where food ought to be. If there's pathology here, I don't think it's in the human body. I think it's in the body politic. I think it's our willingness to tolerate bad diet quality, to tolerate industries making money from making people fat and sick. What I'm showing you here is a New York Times Magazine cover story by Michael Moss. If you're not familiar with Michael Moss, I certainly recommend you become familiar. He's a Pulitzer Prize-winning investigative journalist, author of 2 great books, Salt, Sugar, Fat, and Hooked, about the food industry. And this New York Times Magazine cover story from 10 years ago was lifted from Salt, Sugar, Fat, his first book, The Extraordinary Science of Addictive Junk Food. That's a pretty provocative title. And the article makes the case. So essentially what's described here is that big food companies, all the major food companies around the world, hire teams of scientists, PhDs, and give them the best tech available, like functional MRI machines, and marching orders to develop food formulations that stimulate the human appetite center so much that people can't stop eating. I don't know whether all of you are familiar with a Lay's potato chip commercial from some years ago, Bet You Can't Eat Just One. But that was backed by research. That was a threat, and they could back it up. And it's not just potato chips, it's almost everything in the modern food supply. And by the way, this is why ultra-processed food is so bad. It's not bad by accident. It's bad on purpose. It's designed to lead to overeating. This is what our patients are up against when we give them advice to eat moderately and be careful with their choices. This is willfully engineered addictive junk food. This is the pathology, and this has been exposed, and yet as a society we've done nothing to stop it. It hides in plain sight, along with the pandemic of bad eating and the pandemic of obesity and all the rest. And we know that ultra processing in the service of overstimulating the appetite center works. So Kevin Hall at the NIH has done a metabolic ward study where he randomly assigned people to the same foods available ad libitum. And the only difference was the degree of processing. So a hyper-processed or ultra-processed diet versus a minimally processed diet, same foods. And simply ultra-processing resulted in overconsumption by 500 calories a day and weight gain. So all by itself, even if you don't change the basic components of the diet, if you change the degree of processing the way the food industry does, you make it easier to eat more food faster before you fill up. You overstimulate the appetite center. It results in overeating, increases the risk of obesity. And the remedy here is as obvious as the problem. It too hides in plain sight. We have these famous 7 words from Michael Pollan: eat food, not too much, mostly plants. I think he's absolutely right in terms of what diet is best for health. And I was asked to answer this question some years ago in a review for Annual Review of Public Health. And I've also been charged with answering it across 4 editions of a nutrition textbook, Nutrition and Clinical Practice, the most recent of which came out last year, the fourth edition. But I reached the same conclusion that Michael Pollan reached. Michael got it down to 7 words. It took me the usual academic 5,000. But when I reviewed all the different dietary patterns that compete for our attention, the answer was no. We don't know which single diet, which name diet is best for health. We can't say for sure that optimal vegan is better for people than optimal flexitarian and so forth. But what we can say is the basic theme of optimal eating is perfectly clear, and that is food, not too much, mostly plants. In other words, mostly eat fruits, vegetables, whole grains, beans and lentils, nuts and seeds, and mostly drink water when thirsty. If you can get that part right, everything else falls into place. And if you don't get that part right, nothing else you do is really going to matter very much. And to be clear with all of you, I'm a clinical researcher for most of my career. I ran the Prevention Research Center at Yale for over 20 years. And I conducted randomized controlled trials and published them. And I conducted meta-analyses and published them and systematic reviews. But despite all the crap I learned in medical school, I can read the writing on the wall, to borrow from Simon and Garfunkel. And I would say the evidence that really matters most is what happens to entire populations of people over lifetimes and generations. And RCTs don't get us that information, but ethnography does. So stepping back, getting the big picture, and we have that courtesy of Dan Buettner, National Geographic Fellow, and the blue zones, the 5 places around the world where people most routinely live to be 100 and don't develop chronic disease. And they're in, as you see, Loma Linda, California, the Nicoya Peninsula in Costa Rica, Sardinia, Italy, Ikaria, Greece, and Okinawa, Japan. Now, note how far-flung these populations are. They span the globe. And think about how different they are culturally. But if all of these populations live to be 100 and don't get chronic disease, what we want to know is what do they have in common? And if we ask that question about diet, we could put diet on a spectrum from animal food predominant and ultra-processed food predominant to the left in red, and plant food predominant and real food predominant in dark green on the right. And all of the blue zones are clustered way over here on the right. They all eat real food, not too much, mostly plants. So by the way, the not too much, you don't really need to worry about, because remember from what I just showed you about Michael Moss, highly processed food is willfully engineered to produce overeating. When you eat real food, that problem goes away. Filling up on a reasonable number of calories is much, much easier to do when you eat real food. In other words, one of the many virtues of wholesome foods, fruits, vegetables, whole grains, beans, lentils, nuts, and seeds, is that they fill us up on fewer calories. So the not too much tends to take care of itself. The blue zones populations all have diets of real food, mostly plants. Some of them are only plants, but most of them are mostly plants, and they all achieve the same blessings. They live long, they prosper with vitality, and they die gently in their sleep, often at the age of well over 100. So these are some of the reasons why diet ought to be a vital sign. There's another one. Our diet is cooking the planet. And frankly, 2 basic comments. First, the thing that causes me the greatest amount of anxiety these days is not the pandemic of cardiometabolic disease. It's not the effects of diet on human health. Even though I'm a physician, even though I've taken care of patients for most of my career, the thing that causes me the most anxiety is that we're going to run out of planet. I have children, and my children are thinking about having children, and I'm not sure there's going to be a viable planet for them to call home. And I imagine most of you worry about the same thing. And I also want to note that in 2024, with planetary health on the ropes and in peril, I don't know whether you need to be authorized by someone or not, but I would say we can no longer call ourselves health professionals if we are not advocating frequently and fiercely for the health of the planet, because we have some hope of being healthy, vital people on a healthy, vital planet, or we have no hope of being healthy, vital people. So this absolutely is our business. This absolutely is in our purview. This absolutely is something we need to be thinking about and addressing. And the simple fact is we're destroying the world because of our appetites. The Amazon rainforest, as I'm sure you know, is beleaguered, and it's been burned down in large measure. And most of that is to clear it for pasture land to graze cattle. So it's the world's appetite for beef that is the leading reason why we are losing the lungs of the world, threatening the treasure of biodiversity. And we don't have to do this because we're constitutional omnivores. We have choices. We don't need to eat meat at all, and we certainly don't need to eat as much meat as the world currently does. And we have the choice of a grand confluence where what we do for our own health and what we do for the environment come together. And this too is part of the case for diet as a vital sign. It's vital to the health of people. It's vital to the health of the planet. And we've heard this in the Eat Lancet report, which looks at a planetary dietary pattern that is optimal for people and planet alike. So let's just dive into this a little bit, looking at this great paper from Michael Clark and colleagues at Oxford University, multiple health and environmental impacts of food. So what they did in this paper, you've noticed, I hope, that my slides are pretty easy on the eyes, right? I don't do lots of charts and graphs. Most presenters do that, but it's pretty damn boring. So I don't do that. I apologize. Here's my one eye chart. But this is important. So if you look at A at the top, this is effects of various foods on human health outcomes. So what we've got here, I can't quite, is total mortality, cardiovascular disease, cancer, diabetes, stroke, and then along the side you see the different foods: whole grains, fruits, vegetables, etc. Right? That's A. Green is good, red is bad. The other colors are sort of in between. So where you see green, these foods have a beneficial effect on total mortality, heart disease, cancer, diabetes, stroke. And then in B, down at the bottom, we've got the same foods, and now we're looking at environmental impacts. So acidification, eutrophication, that's nitrogen use, greenhouse gas emissions, land use, and water use. Green is good, red is bad. It's a lot to look at. It's important, but we can simplify. So they also published this, and this is a summary. So on the x-axis here, you see relative risk of mortality. So the further you are to the left, the better. And on the y-axis, you've got environmental impacts. So the closer you are to the bottom, the better. So the bottom left is a good place, and that's where you see everything in green. And the top right is a bad place. And what's the message here? Well, all the stuff that is good for humans, vegetables, fruits, whole grains, legumes, nuts, is good for the planet. And all the stuff that's really bad for humans, red meat and processed meat, and in general, more processed foods, to some extent dairy, is bad for the planet too. So we have a direct overlap between diet that's optimal for human health, diet that's optimal for planetary health. And by the way, that need not have been the case. That's fortuitous, but thank goodness for that. But yet another argument for diet as a vital sign. So if we think about dietary patterns best for human health, dietary patterns best for the environment, the sweet spot is in the middle. And oh, by the way, that is kinder and gentler to our fellow creatures too, who suffer horribly to satisfy the world's appetite. So if we adopt an optimal dietary pattern, we can save the world's wild places. We can preserve the Amazon rainforest. We can preserve biodiversity. We can preserve aquifers much more effectively. We can stop torturing domestic animals, and we can save the spaces that wild animals need to call home. There are many reasons why we're not getting this job done. That's a bigger topic than today's interaction allows for, but let's note one of them. There's an expression from the world of business. And by the way, I'm now in the world of business. So I'm now an entrepreneur. I founded a company, and I'll tell you why I did that. But I want to talk a little bit about what I do and why I do it. The expression comes from the world of business that we manage what we measure. And it's equally true in medicine, where the things that matter most, that need to be managed, we don't just measure, but we measure them again and again and again, and we compare the measurements to targets, and we call those things vital signs. An example is blood pressure. So we measure blood pressure. We measure it very specifically, usually in millimeters of mercury, systolic over diastolic. And then we have population level nomograms to say whether it's in a healthy range, whether it's too low or too high, and then treatment protocols to get it where it ought to be, because it's really important. So we measure it in the service of managing it. We manage what we measure. Now, measurement is not enough to manage something, but it's the place to begin. It's not sufficient, but it's necessary. And when that op-ed was published in the New York Times back before the pandemic in August of 2019, Our Food is Killing Too Many of Us, if you remember that slide, the authors obviously went on to talk about what needs to be done to fix this. And the first thing they said is that hospitals should include nutrition in every electronic health record. In other words, we ought to be measuring this badly broken thing so we can start to try to manage it. And the American College of Cardiology, American Heart Association has subsequently reached exactly the same conclusion, recommending that diet is so important in cardiovascular medicine, it should be measured and tracked with every patient and every clinical encounter. If only we had a tool that could do that. If only we had a way of measuring diet quality as efficiently as we measure blood pressure. And we haven't had such a tool until recently. We've had 24-hour recalls, which are inaccurate and painful, and generally you need multiple recalls to get some reasonable reflection of overall diet. You have food frequency questionnaires, which can take 90 minutes to complete and then first have to be analyzed at the end of one level by a dietitian. That's very expensive. You can keep food diaries for 3 or 7 days and submit those to a dietitian for analysis. Also, very time consuming, very tedious, very expensive. So we've not had any method available that could make diet a vital sign until now. And this is what I do. So I was asked to talk about the evidence-based case for diet as a vital sign. I also want to make clear I put my efforts where my mouth is. So if I think diet ought to be a vital sign, I'm actually working on making that possible. So I'm responsible for inventing and patenting the first fundamentally new way to assess dietary intake introduced in about 50 years. I can't tell you why it's me. It just happened to be me. It could have been somebody else. But what we did was reverse engineer dietary assessment. So instead of asking people to badly misremember exactly how much of exactly what they ate, how many times in the past 6 months, we said people are really bad at remembering details, but they're really good at recognizing familiar patterns. So what if we develop a comprehensive map of diets with diet type on the x-axis and diet quality on the y-axis measured objectively using the healthy eating index, and turned all of those different dietary patterns, every cell in the map, into a collection of meals and foods and turn that into an image? And then play a game with people. Which of these looks more like stuff you eat? And it's just like a visit to the eye doctor, where you look through a phoropter. That's this device on the far left. It's a very sophisticated device, lots of physics and optics embedded in the device. But for the person, the patient using that device, it's unbelievably simple. You just look through the lens, and the optometrist or ophthalmologist asks you, which picture of balloons is more in focus, top or bottom? And you say bottom, and then you get two more images, and they say, how about now? And you play again. I imagine many of you have played this game. As you can see, I certainly have played this game. And within a minute, you have an exact prescription for your eyes and diopters. Well, we invented that for diet. We play that same game. Which looks more like stuff you eat? A or B, A or B, A or B, A or B. We've got you. And we can complete a comprehensive dietary assessment in 60 seconds. I was privileged in developing this innovation to work with some of the best in nutrition. I trust many of you know Walter Willett, former chair of nutrition at Harvard. We also work with Frank Hugh, the current chair of nutrition at Harvard, Christopher Gardner, Stanford University, who's now has this famous Netflix feature, "You Are What You Eat." David Jenkins, who invented the glycemic index. Mary Mirimi, who's an international nutrition influencer, doing much of her work in Kenya and much of it here in the U.S. Linda Snetzler, editor-in-chief of the Journal of the Academy of Nutrition and Dietetics, and on it goes. So work with luminaries and develop this. And again, we can generate a comprehensive dietary assessment over any digital interface, including any smartphone, in as little as 60 seconds. And we can report out diet type, diet quality measured objectively using the Healthy Eating Index 2020, intake of all the different food groups and servings per day, and intake of over 200 nutrients in grams, milligrams, micrograms, whatever units are appropriate. So again, I'm not pitching this to you. I want to make clear that I'm actively working on solving this problem. Basically, we say that diet ID is to diet as the blood pressure cuff is to blood pressure. It's now possible for diet quality to be a vital sign. And this is an image from inside the map where you're looking at two images of food and choosing which one looks like more like how you eat. Now, for many of you, the way you eat may not show up there, but we'll get to that in a minute. So again, we've taken a 90-minute food frequency questionnaire, distilled it down to an easy, fun 1-minute interaction. The other thing we can do with this technology is help people personalize a goal diet based on two things. First, what problems they want to solve with diet. So what are their health objectives? And second, how are they actually willing to eat? Because no diet's ever helped anybody who wasn't willing to eat that way. And then we can personalize the behavior change support. So it's not just about eating better in general. It's about their personal journey from where they're starting to where they're going. So we have personalized behavior change. The sequential changes you make are kind of like a GPS turn list, right? GPS doesn't just help you go north. It helps you get exactly where you want to go. You put in the address where you're starting, you put in the address where you're going, and it tells you how to get there in a sequence of turns. We've done that for dietary change as well. And importantly, our diet map is multicultural. So, for example, and because we're a multicultural society and we're obviously a multicultural world, so if somebody living in the US is from Mexico and they want to fix hypertension with diet, it doesn't do them any good to recommend the DASH diet because they look at that and say, this is not how I'm willing to eat. But what does help them is to take a Mexican American diet at a very high quality level and guide them to that. And it has all the same benefits as the DASH diet, but it features familiar foods. And we have, by the way, two South Asian or Indian diets. We have omnivorous and vegetarian, but we're expanding our multicultural diet map all the time. And these are some examples of how we translate different qualities of dietary patterns into different cultural dietary patterns, Mexican, South Asian, Caribbean, Southern American, but we have many, many others, and we're adding more of these to the diet map all the time. And this is designed to empower both the patient and the clinician. We have a clinician-facing dashboard, comprehensive information. Comprehensive dashboard. So we've designed this to empower clinicians. And we have, of course, validated this. So those of you who are interested in learning more about this, the means of making diet a vital sign, go to dietid.com and click on science, and you'll see all our published papers. But we have published papers against food frequency questionnaire, recalls, biomarkers of cardiometabolic health, biomarkers of dietary intake. And we've now deployed into, this is a very truncated list, into, I think, close to 20 NIH-funded studies at major universities throughout the US, and in some cases, I think, in other countries as well. The other part of the argument for making diet a vital sign is economic, because, essentially, think about blood pressure for a second. Imagine we didn't have blood pressure cuffs. So imagine we knew that blood pressure was really important, and it was a leading cause of heart attack, stroke, blindness, kidney failure, but we never measured blood pressure in individuals. Well, how would we know it was broken? We would wait for heart attack, stroke, blindness, and kidney failure. And then we would say, your blood pressure was broken. If only we had fixed it 10 years ago, but we'll try to do something about it now. So we measure blood pressure to get upstream. If we find hypertension and fix that, the heart attack and stroke never happen. So the same is true with diet quality. It's an upstream variable. If we fix that, we improve biomarkers. If we improve biomarkers, we prevent incident chronic disease. We can fix prevalent chronic disease. And all of this translates into an economic benefit. People who are less sick cost a lot less money for whoever's spending on healthcare. So we published a paper in the American Journal of Health Promotion, The Financial Case for Food as Medicine, Introduction of an ROI Calculator, where we connected these dots. The linkages among objectively measured diet quality, effects on biomarkers, effects on incident and prevalent chronic disease, and the associated costs. So help yourselves to this paper and help yourselves to the calculator. The calculator is also available on the Diet ID website, and it's freely available for anybody to use. So any of you involved in population health who want to know what would happen to downstream health outcomes and cost in a given population if I were able to improve diet quality by this much or that much, the calculator will directly answer that question. And then finally, I've already mentioned the overlap between public health and planetary health, personal health and planetary health, the importance of diet at both. So we have this unique intellectual property, a diet map, diet type on one axis, diet quality on the other. We noticed early on that there was an incredible gradient there in the environmental footprint of diets. So at the bottom left, where diets are low in quality and high in animal food, the environmental impact is huge. At the top right, where dietary patterns have minimal processed food and are plant exclusive, the environmental footprint is tiny. So we thought, well, we can take quantitative scales of the environmental impacts of different foods and aggregate them up to the level of overall dietary pattern. And we can create the world's first app that says, okay, here's your current diet, here's your environmental footprint score. Here are some alternative diets for you that are responsive to your health goals. Here's their environmental footprint. And you can now choose a diet that's good for you that has the smallest possible environmental footprint. We call this project DIEM. DIEM stands for Dietary Impacts on Environmental Measures, but it also comes from the expression I'm sure you all know, carpe diem, seize the day, because we're running out of time to do something to save the planet. We really do need to seize the day. So this is the DIEM project and the DIEM score. So we're looking at 4 component measures of environmental impact: greenhouse gas emissions, land use, water use, and nitrogen use. We have quantitative databases for the contribution of individual foods to each of these. We're scoring the foods, we're aggregating across these 4 measures, and then we're taking the foods and bundling them into dietary patterns and scoring the dietary patterns. And to the best of our knowledge, that's never been done before. And we plan to make this app available later in the year. and it will be a numerical scale, 1 to 10, 10 being the optimal, 1 being the worst, or vice versa. We're still figuring out the best way to share this, but essentially, we will score the environmental impact of different diets and coach people to choose diets with the least environmental impact. Probably best that the high number be the higher impact, the low number be the lower impact. We're still working on the product design, how we want to display it, but it's coming soon. So we are trying to seize the day, because we've long had, the weight of our patients' health on our shoulders. But frankly, as health professionals, we now have the literal weight of the world on our shoulders. And by getting to diet routinely, by measuring it in everybody and managing it as a matter of routine and as an imperative, we have the possibility to save the world. And so I'm going to wrap there with this comment. It's really not what we don't know about diet that most threatens our health. It's the constant misrepresentations of what we do know and our failure to turn our knowledge into the power of routine action. That is my evidence-based case for diet as a vital sign. And with that, I will stop sharing my slides and be delighted to take questions. I hope I was clearly audible throughout and that you could see the slides just fine. It's odd, right? I mean, we do everything virtually these days, and there are lots of advantages, but one of the disadvantages, you have no idea what's going on in your audience. And when I go into slide presentation mode, as I'm sure all of you have done, I can't see you. I can't see anything. I don't know what's going on. I hope that was well received. Thank you very much. Again, happy to take questions. I'm looking at one, so I'm opening the chat now. And anybody wants to ask a question, please feel free. See a few questions here. Any alignment between SDG goals, sustainable development, and whole food plant-based? Absolutely, yes. Again, extensive work. The Eat Lancet report is all about that. Eat Lancet 2.0 is coming out soon. That's all about the overlap of sustainable development, optimizing human health, minimizing degradation of planetary health. But this group at Oxford continues to publish on that topic and show the overlap. It's pretty clear now that optimal diets for human and planetary health overlap substantially, and the more plant-based, the better. Where a lot of the focus now is the economics of that at the individual level. What's affordable, what's not, what's accessible, what's not, what's available. There is, from my point of view, some very misleading literature on this topic, because what some authors, usually with ties to the beef or dairy industry, will tend to do is point out, okay, but if we take away animal food from the diets of people who are food insecure, then their diets are going to go from marginal to inadequate, and they're going to suffer. Health is going to get worse. And they're right. If you take something away and don't replace it, in people who are struggling to get enough dietary variety and enough to eat, things are going to get worse. That's not the point. The point is these studies that look at optimal diets invite us to replace it. So, we need to make high quality legumes more routinely available around. We need to make the plant foods that optimize the benefits to human and planetary health more available. So obviously social equity enters into this, distribution patterns, basically managing the global food supply so it addresses these problems. But yes, clearly there is an alignment between SDG goals and whole food plant-based eating. There was another question about which one I rely on the FFQ or repeat 24-hour recall, and why. I dislike both. Everybody who's ever tried to use them dislikes both. So again, a food frequency questionnaire, you could argue it's the state of the art in epidemiologic research, although frankly, we think we're going to change that at Diet ID because we're deploying it to more and more studies. We actually have deployed into studies at the NIH now. The problem with the FFQ is nobody really can remember exactly how much of different things they ate over the last 3 months or 6 months. And nobody can remember exactly how often. And if you think about the way we eat things are combined. So let's just take, a common example of French fries with ketchup. It's not just how many French fries you're supposed to remember, but how much ketchup. Nobody knows, right? Truly nobody knows. So every answer is inaccurate. And it's usually a 90 to 120 minute exercise. It's extremely painful. So in my own research, over the years, when we were looking at diet quality as an outcome, we use semi-quantitative food frequency questionnaires. The other advantage of the FFQ is that it can be translated directly into a diet quality score. You have to, so we use the Harvard FFQ. We submitted the results to Harvard, and they were able to generate an HEI score. So that's very advantageous. You definitely get better information from multi-day food journals, but wow, the burden is so high, right? So you're asking people to record everything they eat for 7 days. So you're dependent on that level of accuracy. But now that's not standardized. People are literally writing down what they eat for 7 days. That has to be analyzed at the end of one level. It's much less efficient, much more expensive. You're essentially paying for hours and hours and hours of dietitian time using software to analyze these. And so, the repeat 24-hour recall has advantages, but the problem with 24-hour recall is not just recall, but it's just yesterday. And people will often, I'm going to let a dog out of my office hang in a second. People will often preferentially report, that, okay, I ate especially well yesterday. And so, yesterday is often not representative of how they eat in general. You solve that problem only partly by repeating the 24-hour recall multiple times. But the major epidemiologic research programs that use 24-hour recall now use the ASA 24 and repeat it multiple times. The simple fact is, this is why I left academic medicine to become an entrepreneur after I invented diet quality photo navigation, because it's so important, because this is a way where we actually can scale dietary assessment. The tools we had are just not going to do it. They're too, imagine if the only way to measure blood pressure were with an intra-arterial catheter. We'd be able to do it, but it would just be too painful. People wouldn't let us do it. That's kind of how dietary assessment is. So we're working to fix that. Trying to see if there are other questions I should get to quickly. How do we monitor the cravings of individuals and change them optimally? Let me quickly address that, and then you can tell me when we're out of time. So, obviously one of the arguments for the GLP-1s is that they actually change food cravings, and they suppress what's being referred to, at least by the makers of these drugs, as food noise, which we might also think about as hunger, appetite, pleasure. Honestly, I'm not a fan of feeding people willfully addictive junk and then fixing it with pharmacotherapy. I really don't like that. So is there a better way to fix cravings? And the answer is absolutely yes. I coined the term many years ago, taste bud rehab. Some people talk about retraining our taste buds. But think about, for example, the foods available to me living in the Northeast of the U.S. and the foods routinely available to you. They're going to be different, right? They may be healthy in all the same ways, but the fruits and vegetables that we eat every day are probably different fruits and vegetables. And the way you prepare lentils may be different from the way I eat lentils. My wife is French, right? So we may have a Southern French preparation of lentils, and you may be eating dal makhani, something like that. So we have the same biology. We are cousins. We're the same kind of animal. We have the same taste buds. We have different cultures. What made us prefer different kinds of food? It was our upbringing. It was our culture. In other words, it was familiarity. We tend to love the foods we know. And so if you want to change people's cravings, you have to help them get to know better foods. So I call that taste bud rehab. It's basically an incremental process. And this, by the way, is built into the Diet ID platform, where we change diet one incremental step at a time. But the idea is, if you gradually dial down salt, and you gradually dial down sugar, and you gradually substitute more wholesome whole foods for ultra processed foods, you give taste buds time to adjust. And there are really good studies going back many decades that have looked at the very issue of, do preferences and cravings and aversions change when you convert people's dietary patterns? And the answer is a definitive yes, generally in as little as weeks. But if you go out, say 12 weeks, so 3 months time, and you incrementally make adjustments, by 3 months out, you can have people craving what they used to find aversive and having aversions to what they used to crave, much more sensitive to salt, so they need much less, much more sensitive to sugar, so they need much less. You can reverse engineer the willful addictiveness of this junk food. So that's the approach I've used with my patients all the years, and I think all of us can do that. I think that's the way to go. Again, I'm not arguing against the use of GLP-1s when they make sense clinically. I just think it's a tragedy and a travesty to willfully propagate a problem at the level of the global population that doesn't need to happen in the first place, and then spend a fortune to have people take drugs to fix it. I mean, essentially, we're getting people addicted to junk as food and using another drug to treat it, as opposed to addressing the problem at its origins. I think we can fix this issue right at its origins, and we should all at least be trying. And then the rare exception, the person who's an extreme case, they would be the candidate for pharmacotherapy, but not everybody. And I'm worried. It looks like we're talking about just, hey, let's ignore the problem of bad food. Let's just put everybody on Ozempic. I think that's a huge mistake.
Thank you. Thank you, Dr. Katz, for a very enlightening talk and very interesting concept of diet as a vital sign. As an anesthetist and intensivist, I know how important vital signs are when we treat patients, and we use various scoring systems where we see the vital signs of the patient to predict the outcomes. But in terms of chronic health and health in the long run, I think diet as a vital sign is a very, very novel and very interesting concept, and something that I think even when we tell this to the patient will be more accepted, I think, because they know that, when they're ill, the temperature is high, they know that that's the tool that they have to use. And if we tell
Right.
them, in the long term, this is what is a predictor of your health, I think they probably will understand it better. We do have a few more questions. Are you okay to take a few more questions? Or
Yes. I can stay a few more minutes.
there's one on intermittent fasting and keto diet and its visibility on long-term metabolic health. And does the app, the Diet ID app, help in addressing the research gaps?
Does it help in addressing the research gap specifically related to
Related
keto and
to
intermittent fasting?
intermittent fasting, yeah.
Okay. All right. So so three questions really. One about keto, one about intermittent fasting, and one about the functionality of the app. And thank you, Amrita, about the issue. Yeah, obviously in anesthesia, carefully measuring things so that you can monitor the safety of the patient and predict outcomes, absolutely crucial. Anesthesiology is probably in the vanguard of that. But yeah, I mean, as I said, diet quality measured objectively is literally the single leading predictor variable for premature death and chronic disease in the modern world. Um, Obviously, ought to be measured in everybody. And the other thing to note about that is that when the blood pressure cuff was first invented, the ability to measure blood pressure routinely was new. So there weren't a lot of people who knew what to do about it. We didn't have drugs to manage hypertension. We didn't have expertise. But the measurement becoming universally available forced people to gain that expertise. We developed treatment programs. We developed various interventions. People became expert in managing blood pressure. The standard of medicine was elevated. Everybody needed to understand how to deal with hypertension because everybody now had that information. My aspiration for diet as a vital sign is it will be the rising tide that lifts all boats. In other words, now that everybody's electronic health record has an objective measure of their diet quality in it, it's a cue to action. We have to be better educated. All clinicians will need to know more. But what do I do with this? And if I'm not expert enough to manage it, who do I refer to? So I think it just the way the blood pressure cuff did, measuring diet as a vital sign should change the standard of modern medical practice. It should change the standard of care. Okay, so back to the question. I'm not a fan of keto. We include keto in the diet map of Diet ID. So if somebody wants to eat keto, we can address that. But remember, I said we put all the different diets into tiers of quality. We actually have 10 tiers of quality for every diet except keto because we couldn't come up with 10 tiers. My dietitians worked and worked and worked trying to come up with a very high quality version of keto. It was impossible. The diet's so restrictive, they couldn't get it above tier 7. Every other diet goes up to tier 10. Keto stops at 7. So in other words, intrinsically, you're having a lower quality diet if you're eating a highly restrictive diet like keto. I'm not a fan. And the answer to the question, what do we know about long-term cardiometabolic health? Pretty much nothing, because we have no significant populations that have managed to adhere to a truly ketogenic diet for an extended period of time. It's a highly restrictive diet. By the way, there's nothing new about keto. You all remember Robert Atkins, the Atkins diet. Atkins' diet was triphasic, and the first phase of his diet was ketogenic. It's called ketogenic in his book back in the 1970s. And then when he republished in the 1990s, both times he calls phase 1 the ketogenic diet. And what Atkins recognized is it was so restrictive, he didn't think anybody could stay on it. So he transitioned them to phase 2 and phase 3. So we basically have a diet that we tried in the 1970s and tried again in the 1990s and have just given it a different name. I'm not a fan. I think it's bad for people in the long run. I think it's bad for the planet. I think the one area where it has definitive benefits is intractable epilepsy. So it's been used for a very long period. This is where the familiarity with the ketogenic diet came from. Essentially starving the brain of glucose, forcing metabolism over to ketone bodies, mimicking starvation. When nothing else will stop intractable seizures, ketogenic diet can do that. Intermittent fasting, totally different story. So I would unbundle the two. So intermittent fasting doesn't say anything about what you eat when you eat. It just says some of the time you're not going to be eating. So I view that not as a dietary pattern, because you could have a Mediterranean diet and do intermittent fasting. You could have a vegan diet and do intermittent fasting. You could have a keto diet and do intermittent fasting. You could have a South Asian vegetarian diet and do intermittent fasting. You could have any kind of dietary pattern you want and do intermittent fasting. And you could do intermittent fasting multiple different ways. You could do time restricted eating every day. You could do a 5-2 pattern where you eat 5 days and don't eat 2. You could do a pattern where you eat for 5 weeks and skip a week. There are lots of different ways people do this. And you could truly fast for a day or two, or you could do a modified fast where you have fluid intake and you have a partial fast for several days. People do it all different ways. It's a tactic. It's a tactic to control calories. Now, some people use it for more than that. Some people use it as a spiritual experience. It's kind of, like rebooting a computer. It's you're sort of rebooting your own self and your life and just getting a grip. So I think there's some interesting advantages for people who use it as a reboot. But for the most part, what the literature shows us is that if you do time-restricted eating or you do intermittent fasting, you're punching a hole in the total caloric intake you would otherwise be getting. And most people do not replace all of the calories fasting takes out. And so the net result is fewer calories in. And the inevitable thing happens when you reduce your calorie intake, people tend to lose weight. When intermittent fasting is directly compared to portion control. So essentially in a randomized assignment, you either have the portions you get multiple times a day, every day, carefully controlled, or you're advised to achieve the same level of caloric reduction with intermittent fasting. When calories approximate with these two very different methods, the metabolic results and the weight results are almost indistinguishable. So there's no metabolic magic in intermittent fasting. It's a tactic. So what I've told my patients and what I tell my audience is if you like that, if you prefer not eating some of the time or time restricted eating to worrying about portion control all the time, if that tactic works better for you, great. If on the other hand, you find that going for an extended period of time without eating makes you dizzy and cranky and unproductive, then it doesn't work for you. And I can't decide. You're the boss of you. You have to decide. So I think it works well for some people, poorly for others. But the one final caveat is if you're relying on intermittent fasting as a tactic for calorie and weight control, don't forget that what you eat when you eat still matters. So my worry about intermittent fasting is people think that that's their diet and then they can eat any junk they want when they do eat. No, the quality of what you eat when you eat still matters. So if you combine a high quality diet with intermittent fasting as a tactic to control total quantity, I think that's absolutely fine. We have in our behavior change module at Diet ID, we could address the issue of time restricted eating, but it isn't a dietary pattern. So it's not part of the diet map because it's a tactic superimposed, and it can be superimposed on any kind of diet. And then finally, the question about our functionality to get at research gaps. I think the best way to answer that is to simply say, again, at this point, we are deployed. My team tells me we're currently deployed into over 20 federally funded studies at major universities. So we are contributing to filling research gaps by partnering with researchers who are able to use our tool to capture information that otherwise was painful. And again, I speak from direct personal experience. We did dietary studies at the Prevention Center at Yale the whole time I was there, and we often used diet quality as a primary outcome measure, and getting the data was nearly impossible because we were relying on FFQs and they were so painful. And we wanted data not just from adults or from kids. So we had parents filling out FFQs with their children. And it was so painful that the only way we could get people to do it was to pay them. And no matter how much we offered them, it wasn't enough. And when we offered them too much, our IRB told us, no, you're coercing them now. It's too much money. You're not allowed to pay people that much. It was really, really difficult. By taking away all that pain and making it possible to get diet quality and track it in a minute, we're enabling researchers to get data they otherwise couldn't get. So they can start to do these studies and not worry about how are we going to capture the data we need about changes in dietary intake patterns. So I hope the answer is yes, that we're helping to populate these gaps in our knowledge, because we, first and foremost, really, we were developed as a research tool, and then everything else follows. So we're very focused on deploying into research.
Thank you, Doctor.
Yeah,
Thank
sorry.
you so much. I'm Dr. Regina. I'm the medical director for Pan India. I've contacted you regarding this webinar. Hello.
I'm here. I'm here. Thank you. I appreciate the invitation. Thank you.
Yeah, Doc. I mean, I've been following you for a long time on Facebook, now on LinkedIn. I keep sharing your most of the articles, and the recent one, the centenarians, which I felt like you were kind of a little, while you were writing that, you were kind of a bit low on the spirit of the the spirit of it, actually. And your mother has actually written something at the end that you have made me and your father to bike around the world or something like that. It was very interesting. Okay, Doc, yeah, thank you. We're so grateful to have you tonight. And it was like a journey from 1993 to 2023. The whole thing appeared like a kind of how the evolution of evidence-based nutrition happened over the last 3 or 4 decades. Actually, it's wonderful. And I'm sure that I myself, though being in the field for the last 10 plus years, I'll take at least 2 or 3 times of going through your recorded session to understand and imbibe everything properly. I mean, so many studies you've shared, wonderful, actually. And I can also see a lot of our doctors who are asking to assist you, to be part of the research, to be part of the project. How can we kind of connect with your team or do something in India and things like that? That is something to be thought about. I'll be in touch with you regarding this, because they're so impressed with the kind of knowledge you've shared just within 1 hour. I've seen at least 6 of them would be wanting to work with you in some way.
That's extremely kind. Okay. Well, first of all, Regina, so first of all, thank you for reaching out to me. Thank you for inviting me, and thank you for the kind words. It's really a pleasure. I'm getting to the stage of my career where I'm slowing down. And I've been working hard for 40 years. And I want to be clear with all of you, because I suspect many of you are much younger than I am. We're not winning the war, right? I mean, when I was a young guy and I signed up for all this, I thought I could fix stuff. That's what I wanted to do. Less obesity, less chronic disease. People are going to eat better. And here we are, 35 years later, and we have more obesity and more chronic disease all around the world. We're not winning the war. So there's nothing I value more than the opportunity to reach out, create new connections, find new colleagues, and in particular, find young, energetic, idealistic, smart, motivated people who are willing to say, here, hand me the baton. Tell me what needs doing next, because I want to do it. I mean, I love that. So I can't thank you enough. This is a beautiful opportunity. I really do appreciate each and every one of you being here. In terms of getting down, I mean, sometimes I'm writing from a dark place. I do have frustrations. I've been trying to fix stuff for 40 years, and the world just keeps pushing back. I mean, planetary health is getting worse. These chronic problems are getting worse. Instead of fixing them here in the U.S., we've exported them all around the world. We're sort of the epicenter of this global pandemic of bad eating and bad health. And, frankly, I'm ashamed of it. But we have to keep trying to fix it. And the value proposition of fixing it is just incredible. So there's nothing I would like better than to establish new direct relationships with people and find ways to collaborate. And certainly, there are opportunities to do that with Diet ID. There are potentially other things we can do together. So you have my contact information, Regina. Please feel free to share that with everybody. I'm pretty easy to find. If you Google me, my email address is readily available. But share the information. I'm happy to share my slides with you. You can give everybody a copy of the deck. Let's make this as easy as possible. But again, I really genuinely appreciate these opportunities to make new friends. Thank you.
Thank you so much. And thank you for all those doctors. I think it was like one moment in time, it was touching around 80 people. This is one of the largest.
Good evening, doctor. Good evening, Dr. David. Yeah, I'm Dr. Purna from Hyderabad. It's been very nice, sir. the session. I'm coming to know very few new things because I lost almost 14 kgs in the last 3 months from September 7th to December 7th. So it is like intermittent fasting along with alkaline diet. So, but I reduced my weight to 14 kgs. It's in the process of detoxification, and I feel 10 to 15 year lesser compared to my age. I am now enjoying like a college student in my UG, like in my UG. So my doubt, my part of question is, sir, to maintain, I like vegetarian diet. I convert to vegetarian completely for the past 3 months, so I want to continue same vegetarian diet entire my life. But how to maintain this B12 levels with a only vegetarian diet? I read some where like having bananas and beetroot and buttermilk. So, if you have such sufficient amount of these three, we will maintain a B12 level in a normal range. Is it true, or anything else is also added to these things?
So B12. So first of all, good for you. I'm delighted you've made a switch, and importantly, I'm delighted you've switched your diet in a way that you feel you can maintain and you want to maintain. That tends to be the problem with diets that people go on. Um, I'm not a fan of going on a diet. So I think diet is a good noun, as in dietary pattern. I tend to think it's a bad verb. I'm dieting because that tends to mean I'm doing it for a little while, for as long as I can stand it, and then I'm going to stop. And it really ought to be about lifestyle. It really ought to be about loving food that loves you back. It really ought to be about change that you can maintain. So good for you. It sounds like you're on the right track. First of all, I don't worry very much about the need for judicious supplementation. So, for example, there are unique human health benefits of long chain omega-3s, but I don't think we should all be eating lots of fish because we're destroying the oceans and we're destroying the fisheries. So I take an algae-based EPA DHA supplement. And, I think that's a perfectly good idea. Those of us who are not out in the sun routinely need supplemental vitamin D. Vitamin D, as I'm sure you all know, is not really a nutrient, it's a hormone. We manufacture it in our skin with sun exposure, but if we're not out exposed to the sun, we don't do that. And then we need to ingest it. And we get it mostly from fortified foods, which is another form of supplementation. So I don't mind judicious supplementation. The same is true of B12. B12 is actually generated by bacteria that are intrinsic to the soil. So plants have B12. They just have low levels. And in order for us to get enough, what tends to happen is we benefit from bioconcentration. So if we eat animals that in turn have consumed plants, they bioconcentrate B12, we get a more concentrated dose. The foods you mentioned have low levels of B12. Another good concentrated source is nutritional yeast. It's probably the single highest, essentially plant-based. In this case, it's a single cell organism, the yeast, but let's call it a plant. It's more like a plant than anything else. That's probably the best single source. And so that can be added, and it's a good condiment. It actually has a salty and astringent quality to it. So it's essentially can be used in combination with herbs, and it can replace salt to some extent. It's a concentrated source of B12. So if you wanted to make sure on a vegetarian or vegan diet that you're getting adequate B12 and you didn't want to just take a supplement, the foods you mentioned plus nutritional yeast would be a good option. On the other hand, my recommendation would be, if you're being seen by a physician periodically, check your B12 levels. And if they're questionable on your diet, don't change your diet, because it sounds like you're doing great. But take a B12 supplement. They're readily available. They're inexpensive. They're perfectly safe. And I think that's what supplementation should be for. It's not a substitute for healthy eating. But if you're eating in a way that is doing all kinds of good things for you, and it's the way you want to eat, and your health is improving, and you feel younger, and you've reduced your biological age, and all that great stuff, I wouldn't let the fact that that dietary pattern is causing a shortfall in one or two specific nutrients discourage you when you can easily use supplementation just that way for targeted population of those shortfall areas. I do the same myself. So that's what I'd recommend.
Thank you very much, Dr. Katz, for being so patient and so patiently answering all our questions. I just have one last question. For Indians, are you introducing the diet ID for Indian food and Indian food patterns?
So it's a great question. So the answer, I'm new to this world. I'm not a business person. I'm a doctor. But it turned out the only way to get this thing to daylight after I invented it was to form a business. And obviously, once you form a business, you've got bills to pay and all the rest. So we are very interested in globalizing the use of diet ID. In order for it to work well in India, we can't just have one Indian diet or two Indian. We need all the different regional diets. So there's a fair amount of work to do to regionalize the use of diet ID. We have South Asian diets in our current map, and we have more than one version. So what we can currently do, we probably can work in a research setting, and we certainly can address Indians living in the U.S. who have, sort of an Indian American diet. So they have a South Asian diet, but adapted to living here. We can cover that. But what I can say is, yes, I certainly have the aspiration and the intention of bringing diet ID to India and Japan and all around the world. But in order to do that, we need to collaborate with experts there, to develop out the population-specific diet map so that it's India-specific. So we are somewhat focused on North America at the beginning. These are still early days for us. We're still a young company. We have the capability of developing population-specific maps for the entire world, but there's time, effort, and consequently some cost involved in doing that.
India is a very vast country, and we are
yes
culturally diverse. The food habits, the cooking, everything changes from state to state, place to place. So I think it's an uphill task, to be very honest.
It is an uphill task, but it's doable. And you'll be interested to know my co-founder and my chief operating officer, Rachna Govani, is Indian. So we kind of have an insight. So we've been looking at that from the very beginning. And I fully understand. Right, it's a big job. But frankly, the US was a big job for a different reason. We're a smaller population, but we're multicultural. We have people living here from all over. So, essentially, if you're going to make this method available in the US, you need South Asian diets, you need Chinese American diets, you need Mexican American diets, you need Cuban American diets. We've got populations from Africa, we have populations from South America, we have Vietnamese, we have Korean. It goes, so we have to include all of that. So the diet map has as much of that as we were able to put in, and we're adding to it all the time. So yes, it's doable, but it would need to be a collaboration with colleagues in India. And one of the things maybe we get to talk about, as people reach out to me is, can we collaborate on that? Can we adapt the diet ID map for use in India? Because we have the technology to do it, but we need additional resources, and we need experts who live there and can help us fully understand all those different regional diets.
Definitely. I mean, PAN as an organization, its mission is to, to make sure that we give the evidence-based information about nutrition. We train and teach and engage and empower the healthcare professionals about nutrition, and making diet and healthy diet as the core of healthcare, essentially. So we are in it with you into this whole
Excellent
mission of mitigating the global health crisis that we have because of the way we eat and the way we do our agriculture and animal agriculture, basically. So thank you very much again, Dr. Katz, for a very, very enlightening session. It was very interesting. And there are a few more questions. Will it be okay if we email them to you and you could answer them at your convenient time?
That sounds fine. I'll do my best to get to them.
Yes. So thank you very much again. And
thank you.
Thank you. Namaste.
It's been a pleasure.
Thank
Namaste.
you. Bye-bye.